In addition to the losses that we have, that is eased somewhat by the supplemental payments that come into hospitals through our upper payment limit or UPL program. When you include those, net losses went down to about $109 million. But still, that's a loss of over $1 million a year in serving Medicaid patients, and we don't see that decreasing any under the current per diem system. So, are we sitting here saying that we need to keep the current system we have? Not necessarily. Certainly it pays inadequate amounts. I think up until 1997, CMS required state Medicaid programs to pay reasonable and adequate amounts to hospitals. That was because something that was in place at the time called the Boren Amendment. That went off the books in 1997, and since then, most Medicaid programs in states across the country have been pretty much free to pay whatever rates they want, whether they're adequate or inadequate. We would say that the current $850 a day is inadequate and certainly needs to be increased. Now, does that mean that we need to move to a DRG system to remedy this? And if things are that bad, why would we even care about that? Well, the point is that if you move to a DRG system and the rates are set at a point where they're actually reimbursing hospitals less than they are now, then those losses could increase. And that certainly has a big implication for hospitals or for all across the state, and certainly the small rural hospitals that I've already talked about. There would seem to be no compelling reason to do that in terms of saving state dollars. Right now, a hospital is paid $850 a day for whatever, based on the number of days that a Medicaid patient stays, whatever the diagnosis is. Whether he's in there for an infection or brain surgery, that payment is going to be $850 a day times 4 days, 6 days, whatever it is. So it's pretty simple to administer. The only variable in there is the number of days that you're going to stay. We've already seen that implementing a DRG system includes a lot of calculations, a lot of gyrations, a lot of data, a lot of effort. Not to say that it can't be done, but certainly we believe that the state would invest a lot in putting together a DRG system versus what they have right now, where that there's, other than the length of stay, there is no other variable to consider in determining inpatient payments. So we'll get back to the key, and that's setting the DRG rates. If you base it on something similar to what Medicare has in place, we know that those rates are adjusted up or down. We already saw in a slide today about 3M that there are at least 10 or 11 different factors that could go into setting rates for hospitals. We're concerned, particularly, again, with the small rural hospitals, that those rates would be even less adequate than they are today. We can tell you that critical access hospitals, which are currently reimbursed based on their costs, for both Medicare and Medicaid, depend on those. Without those allowable costs of reimbursement, they're not going to exist. Without the supplemental payments they get through the UPL program, they're not going to exist. More than 20 local communities support their hospital with things like local sales taxes. Many of those in communities that have critical access hospitals. Without those local sales taxes, I think most critical access hospital CEOs will tell you that those hospitals won't exist. The same is true for a lot of just other small hospitals that don't get the benefit of the 100% cost reimbursement. They rely on every dollar of revenue that they can get, and so they are understandably concerned that moving to a DRG system would see their total Medicaid payments reduced beyond that 52% that Bo has already talked about. So there are definitely some implications here. We think that the concerns are valid. Not to say that everybody again is crazy about the per diem rate that we have, but as they say that when the devil is in the detail, the devil you know is better than the devil you don't. And right now the per diem system is the devil we know.